Yeah, you can see your slides.
Is it big enough or?
Let me make it bigger. I think this is bigger. Okay?
Yeah.
Yeah, I'm just going to start with a slight intro, okay? So good afternoon, guys. So as you know, we are on the cardiorespiratory system. This is the fourth session for the teaching this week, this month. And we have a couple of other topics to cover before we move on to the next system. Today we have two presenters with us. One of them is Jay, who's kindly agreed to present on the audit that he is doing on the ICU. And the other presenter is Isabelle. She's going to talk about cardiac output monitoring methods. Okay. So we're going to start with Jay. Jay, do you want to crack on, please?
Yeah, perfect. So I'm one of the ACCS trainees. I just finished my ITU block yesterday, but whilst I was on the unit, I was doing an audit on ventilator-associated pneumonias. So I'm just going to run through exactly what they are, what we found, and just some points for improvement that I've picked up. So ventilator-associated pneumonias are essentially a form of nosocomial infection, hospital-acquired infection, that presents after 48 hours of mechanical ventilation. Figures in terms of prevalence and mortality are quite broadly quoted, ranging from sort of 8 to 30% in both categories. But importantly, new research that's coming out is suggesting that, particularly with mortality, with preventive strategies around ventilator-associated pneumonias, we can reduce our mortality by about a third to 9 to 13%. So there's a scope of an improved practice to really help with our patient outcomes. Besides mortality, VAPs increase number of days of a patient on a ventilator. They increase overall ICU beds. Well, they increase ICU admissions, but also overall hospital length of stay. And those sort of three things grouped together in this sort of NHS age of, heightened financial awareness, that all contributes to the financial side of things as well. So I polled the SHOs on the ICU over the past few weeks about their knowledge around VAPs, and seems like sort of the majority of SHOs and ACPs knew about the diagnosis of, well, when we can diagnose a VAP. So that sort of knowledge was there, but people weren't all that confident around about diagnosing ventilator-associated pneumonias. I think most of the people that answered my questionnaire were maybe a little bit hesitant and maybe not so confident about what it takes to diagnose a ventilator-associated pneumonia. So essentially, there's no hard and fast criteria for diagnosis, which I guess is why maybe our confidence levels aren't so high. But lots of information feeds in to going to diagnose a VAP. So there's a clinical suspicion, is the patient having a rising FiO2, or is there secretion burden that sort of the nurses are picking up on their suctioning, is that increasing? We want to also look at, potentially our auscultation as well to help feed into that sort of clinical suspicion. We want to look for chest X-ray changes, quite self-explanatory there. And also we want to make sure that our microbiology can help us as well. Particularly sputum cultures can give us essentially a bug that would confirm our suspicions of a ventilator-associated pneumonia. And again, when I asked you guys, lots of people knew lots of the things that might feed into a diagnosis. One thing that is important, I think, is secretion. So when I was doing research, increasing secretion burden is quite sensitive to an early diagnosis of a VAP. So that's something not just to ignore when you're doing a ward round. You know, if the secretions are going up and they're becoming thicker and a bit more purulent, that is something to definitely take note of. So going on to essentially how we might want to go about preventing ventilator-associated pneumonias, or what risk factors there are. Essentially, we can group them into 3 categories. So the way that we think that VAPs develop is that when the ET tube is sort of in place in the trachea, micro aspirations on a very small level can track down from the upper airways into the lower airways, settle in the bronchioles and maybe in the alveoli, and then that provides a sort of petri dish for bugs to grow in, basically. So anything that we can do to minimize aspirations around our tube or micro aspirations is certainly a good thing. So 3 things that we can look at there are making sure that we're nursing our patients in the head up position, so around about 30 degrees, making sure that their the oral hygiene is good, you know, washing with chlorhexidine, and that's the little you know, on the first page of the drug chart, those 2 little boxes there that you prescribe, that's your sort of chlorhexidine mouth care prescription, which is important that we all do. And lastly, the subglottic aspiration, so making sure that we're getting that catheter down the ET tube into the lower airways and sucking out any secretions that are there to try and prevent those conditions for bacteria to grow in. The next sort of grouping of things is well, the next 2 groups I should say is all about minimizing time on the ventilator, minimizing complications and length of stay. So making sure that we've got PPI prophylaxis and VTE prophylaxis, and making sure that we're considering sedation hold every day to try and make sure patients aren't on the ventilator for, you know, a minute longer more than they need. When I asked you guys what risk factors you thought were there, you guys came up with some really good ones. So on top of that, you know, making sure our cuff pressure is adequate, making sure our patients are getting good physio, and that all of our equipment is nice and clean and sterile. So making sure that we've got antibacterial filters, you know, in our circuits, and potentially using humidified circuits as well. But those ones that I first talked through, and those ones that are in the box there, those are high-powered interventions which have been proven to reduce VAPs, which have been grouped into this Northwest London ventilator-associated pneumonia care bundle. And these are essentially, this is our VAP bundle that we should be adhering to, and all patients should be receiving those 6 interventions to reduce the prevalence of VAPs. So just briefly talking about what I found when I had a look around. So I basically audited 30 days of data, and I got those from 21 patients, because I think at that time movement in and out of our ICU wasn't particularly speedy. Patients have been on an average of 4.9 days on a ventilator, and they were there for a variety of reasons. The things that we're all sort of pretty used to seeing, so decompensated ALD, pneumonia, COPDs, COVIDs, those sort of common diagnoses. So it was a reasonably representative population, I would say. I found that, so going through our interventions, all of the patients that are on all of the days of data that I collected, every single patient was being nursed in the correct position. They all had oral mouth care, and every single patient had appropriate VT prophylaxis. So, you know, if they were having an upper GI bleed or coagulopathic, they obviously weren't having it, but anyone that should have been prescribed it was being prescribed it. Now, we set our standard at 90%, and we found that the next 3 sort of areas, PPI prophylaxis, subglottic aspiration, and sedation holds, weren't being, well, our targets weren't being met. Particularly sedation holds, we would only just about 50% of our patients were being, you know, and not only patients that actually had one, but were even being considered for one on that day. they were sort of only at 57%, so quite well below what we should be doing. Now it's it's quite difficult, I would say, to go about and sort of intervene with these things, but I would just say that a lot of these interventions are sort of at SHO level. When the consultant's going around, he might not check that there's been adequate subglottic aspiration. They might not check the VT or PPI prophylaxis, and so these things are coming down to us as SHOs to make sure they're being done. Particularly with sedation holds, if the consultant's not offered it, just quickly pose the question at the end of seeing that patient, and then on the chart there's a little tick box that you can just either put a tick or a cross into to make sure that it's being considered. And I think that that is a really important piece of documentation for us to do, because that is a standard that we should be adhering to, a daily sedation hold. So I guess this is just to highlight the fact that maybe we're not as good as we thought with some of the basic things that we should be doing. And they can also be very easily corrected as well, just with a quick look at the drug chart or a cursory question to our nursing colleagues or to the consultant doing the round. Just out of the patients that I surveyed, 3 of them were diagnosed with a VAP, and 1 of them died, but with a cause unrelated to the diagnosed VAP. So actually, our prevalence of VAP, albeit this was a very small sample size, wasn't too bad. It was sort of at the lower end of the quoted prevalence that I found in the literature. So essentially, what I want you guys to take away from this is that I think that there is an understanding of VAPs among our SHO cohort, but potentially maybe not the confidence to go around diagnosing it or to, think about it actively when you're going around seeing your patients. So just on the next few days that you guys are going around, just try and have it in the back of your mind, that sort of VAPs can cause significant mortality and morbidity to patients, and undertaking some pretty straightforward SHO level interventions, we can take big steps to minimizing those risks. And basically, we should just be a bit more confident going around making those decisions. The one thing that I maybe should have looked at that I didn't think about when I first started my audit was to see whether the diagnosis of a VAP was increasing our patient times on the ventilators or on the length of stay. So that's something that maybe if this cycle was done again, that could also be looked into. So I'm going to start my second cycle of recollection data in the next few days and weeks. So that's where I'll be going with this. So yeah, those are my take-home points, and thank you for listening, everybody.
Thank you so much, Jay. That was very, very interesting. Just out of interest, other than this education session that you have done, what sort of action plans are you thinking about to improve this problem? And
yeah, so there, I'm sure you guys have seen. There's probably I put up a few posters in the doctor's office just to nudge you guys when you're going on your round, and I think so. This is being audited more generally by the nursing staff. I particularly wanted to look at what the confidence level was and sort of amongst the SHOs, and to maybe empower us as an SHO cohort to just think about it a bit more. So potentially we could link up with the nursing staff for which lots of this stuff does get audited, to maybe increase the sample size and give us some maybe more accurate data about the VAP bundle interventions. Okay,
that's amazing. Anybody else has any questions, comments on Jay's presentation?
In the category of patients who didn't have a sedation hold, did you account anybody in whom a sedation hold was contraindicated?
Say that again, sorry.
In the patients in whom didn't have a sedation hold,
yeah,
but one wasn't discussed, did you account for patients in whom a sedation hold is contraindicated?
No. That's a really good point. Actually, I didn't do that. So yeah, I should, that'll be definitely something that I factor into when I next go around. Actually, that's a really good point.
All right, perfect. Anybody else? Anybody from Microsoft Teams? Any comments? Any questions? Please, you can ask now.
Just out of curiosity, how does VT prophylaxis help with preventing aspiration?
Oh, so the VT prophylaxis side of things wasn't around microaspirations. That was all about reducing complications within our patients. That increases length of stay, slow progression in the intensive care unit, which leads to patients being at more higher risk of VAPS if they're on a ventilator for longer. Okay. So that wasn't specifically around aspirations.
Okay.
All right. Thank you so much. Anybody from Microsoft Teams, guys? Any questions? Any comments? Any compliments? Okay. So we'll move on to the next presentation. Thank you so much, Jay.
Thanks, guys.
It was amazing. We'll move on to the next presenter, which is Isabelle. She's going to talk about cardiac output monitoring methods in the ITU. Isabelle.
Can you hear me now?
Yeah, we can hear you. That's
great.
amazing.
I'll turn my camera on as well. Sorry about that. I'm very low down. Okay. Yeah, sorry, my laptop decided to give up on me, so I'll just share my screen. That's fine. Okay. So can you see it?
Yeah.
And is it moving?
Yeah, that's moving.
Okay, great. Okay, yeah, so hi, I'm Izzy. I'm one of the SHOs at Ealing. I have been asked to present on cardiac output monitoring in intensive care today, so I'm going to do my best. Please feel free to jump in if you have anything to add. So just an overview of what I'm going to go through. So I'm going to talk about why we might want to measure the cardiac output, what we might see from the bedside in terms of a patient with reduced cardiac output, talk through the FIC principle, some various methods of measuring cardiac output in intensive care, a brief comparison of these methods, and that'll be the end. So to start off with, why do we want to measure cardiac output? So in a large proportion of intensive care patients, particularly shocked patients, the goal of therapy is to maintain oxygen delivery to the tissues. And a key way of doing this is to maintain the mean arterial pressure. And the mean arterial pressure is actually the cardiac output times by the total peripheral resistance. So if we take an example of a patient in septic shock and look at this diagram on this slide here. So a patient with septic shock is going to have this widespread peripheral vasodilation, so a reduction in the systemic vascular resistance, which might contribute to reduced MAP. But they also might have a reduced blood volume, so they might be a bit dehydrated. And we also know that septic shock can affect the inotropy of the heart, so they might have reduced cardiac myocardial contractility as well. And this would reduce their stroke volume and in turn reduce the cardiac output. And so you can see how measuring the cardiac output could help to guide our treatment in trying to maintain the MAP. So the first way that it can be used is as an indicator of essentially how unwell the patient is. So it's been linked with having a reduced cardiac output has been linked with increased morbidity and mortality in the intensive care. And it might indicate to us that some of these mechanisms in the diagram here are not functioning as they would be in a healthy patient. The second way we can use it is to guide treatment. So a lot of these shocked patients are going to come in for blood pressure support, so they're going to be on vasoactive inotropic medications. And using the cardiac output and also parameters associated with it, we can actually guide the use of these medications. So depending on what kind of effect we want it to have on the body, we can choose the right drug to start with, and then also monitor the effects of these drugs by monitoring the change in the cardiac output over time as well. So I thought I'd just touch on the bedside indicators of a reduced cardiac output. All of the consultants, I'm sure, will tell us that looking at the patient is the first thing that we should do. So in terms of our examination, so the patient might have pale mottled skin, cool peripheries, have a weak pulse, they might be confused. If they have some cardiac congestion, reduced cardiac contractility, they might have some fluid overload, shortness of breath, peripheral edema. We can also look at the blood pressure. As we discussed, the cardiac output is directly contributing to the mean arterial pressure. And then in tandem with that, their vasopressor requirement as well. We can look at their heart rate, which might be compensating for a reduced cardiac output, and also the urine output. So if we have renal vasoconstriction to try and preserve the blood volume in response to a reduced cardiac output. So obviously these signs can all indicate an inadequate cardiac output, but aren't particularly specific. But there may be things that we can use to indicate that we might want to start measuring the cardiac output, and particularly say a patient has climbing vasopressor requirements, then we might want to think about starting to measure the cardiac output so that we can guide the treatment more specifically. Okay, so how do we measure the cardiac output? So I'm going to try and explain the Fick principle here in simple language. So it's first described by Adolf Fick in 1870, and it's based on the principle that the total uptake of a substance by a tissue is equal to the blood flow through that tissue or organ times by the arterial venous concentration difference of the substance when it goes through that tissue. So it was first described using oxygen, and it basically means that if you know the oxygen consumption of an organ, so you know the amount of oxygen going in, and you know the concentration of oxygen in the blood before it enters the organ, and you know the concentration after it leaves the organ, so the concentration difference, you can figure out how much blood is flowing through that organ. And blood flowing through the organ in the case of the heart would be the cardiac output. So this is called the direct Fick method. It's seen as the gold standard of cardiac output monitoring, but it's actually rarely used in practice. And the reason for this is that it involves measuring the expired O2. This is in order to get the oxygen consumption. And this is apparently quite impractical, quite difficult to do clinically. So it's not often used. So this created the need for a kind of development of modifications of this principle and alternative ways of measuring the cardiac output, which brings me on to the dye indicator dilution or thermodilution method. So this is a modification of the Fick principle, and it basically swaps in that oxygen that was being measured before for other indicators which are easier to measure than the oxygen. So the first example of these is lithium. So if you inject a known volume of lithium into the venous circulation, and you then measure the the lithium concentration in the arterial circulation or the blood leaving the organ, then you can work out the volume of blood flowing through the organ. So it's a similar principle, just using the known volume rather than the oxygen consumption as previously mentioned. Lithium is just used because it's a relatively non-toxic chemical. It's also not found naturally in the body, so it's not going to get confounded by natural lithium in the body, and also it's not going to metabolize as it goes through the organ or the heart. The other method you can use is thermodilution. So this involves an injection of cold saline into the venous circulation, and then the temperature is measured in the arterial circulation, and then the temperature difference between those two can determine the blood flow through the organ or the cardiac output. So these are just used because they're easier to measure than the oxygen consumption. There are also other kind of dyes that can be used as well, but these are the main two that I'll focus on in this talk, which will become clear in a second. So this brings me on to the pulmonary artery catheter. So this is a line that goes in through the right internal jugular vein or the right subclavian. It's basically the original cardiac output monitor, and it was first introduced in about 1970, and it's also known as a Swan-Ganz catheter. And it basically consists of an injection port, which is at the entrance of the right atrium, and then the line itself actually goes through the right atrium, the right ventricle, before it has a balloon inflated in the right pulmonary artery. And it also has a thermistor tip, so that can measure the temperature there. So the way that this measures cardiac output is that you would use thermodilution. So inject 10 to 20 mils of cold saline at the entrance of the right atrium, and then measure the temperature in the right pulmonary artery. Based on the principle of thermodilution, you can figure out the blood flow through the right side of the heart. And then this is assumed to be the same as the left side of the heart because it's a closed circuit. This is seen as sort of the next best thing to the Fick principle in terms of measuring the cardiac output, and it's actually the method that all other methods of cardiac output monitoring are compared to in studies. But the main problem is that the pulmonary artery, as you can see here, is the pulmonary artery catheter is quite invasive, so it has quite a high complication rate. Although there are some studies that show this isn't actually associated with an increased mortality, but it's also quite difficult to insert. So in terms of complications, you can cause arrhythmias during insertion. You can, as with all lines, introduce infection. But obviously, if it's going through the right side of the heart, then this could mean you cause an endocarditis. It can cause a pulmonary artery rupture or an infarction, and also this thing called knotting can happen. So essentially, if you look at here, so if it doesn't quite get through the tricuspid or the pulmonary valve, then you can end up with too much length in one of the chambers of the heart, and that can actually knot on itself or coil on itself, which can obviously be quite problematic when it comes to removing it. And then, yeah, if you do have a traumatic removal, it can cause valve damage. The other thing with this is that this method of thermodilution can't be accurately relied upon for left cardiac output if there's things such as valve dysfunction or there's a cardiac shunt, so a right-left shunt, then you wouldn't get an accurate reading for the cardiac output. So to avoid requiring an invasive line like a pulmonary artery catheter, other methods of cardiac output monitoring have been devised. So the first one I'm going to talk about is pulse contour analysis. So this is based on the idea that the area under the curve of the arterial line waveform is proportional to the stroke volume. So you can figure out the stroke volume using an algorithm based on the arterial line waveform. And obviously, if you can estimate the stroke volume, then you can times that by the heart rate to get the cardiac output. This is really good because it can provide continuous cardiac output monitoring because you have a continuous arterial trace. However, the main problem is that it's really affected by arterial compliance, which is normally okay in a healthy person, but in intensive care patients who are unwell, this can change quite rapidly because it does change in response to things like rapid blood loss, septic shock, and rapid temperature changes. So you can't actually rely on it to consistently provide an accurate reading over a longer period of time. This is, however, the method that a couple of the commercially available cardiac output monitoring devices use, which I'll go into now. So the PICO, which is the pulse index contour continuous cardiac output monitor, which I've come across in Ealing, and I'm sure a lot of you have come across as well. This uses pulse contour analysis, but in order to get around this problem of the arterial compliance, it also uses thermodilution as a calibration technique. So the pulse contour analysis will be running continuously, and then the thermodilution will be used every 1 to 4 hours to provide a more gold standard method of measuring the cardiac output, and just to check that the pulse contour analysis isn't completely far off the true value. It also, so the way you do it is you insert a central arterial line, so it needs to be a femoral arterial line, and you need a CVC, and it uses thermodilution where you put the cold saline into the CVC, and then you measure the temperature in the femoral artery. So this is actually not just measuring blood flow across the heart itself, but across the whole thorax, which actually means that you can calculate some derived indices, or the machine can calculate some derived indices from it. So the cardiac index is just the cardiac output divided by the total body surface area of the patient. But the global end diastolic index is essentially a measure of preload in the heart. The external lung water index measures basically pulmonary edema, extravascular lung water. And then the systemic vascular resistance index tells you about the systemic vascular resistance. And you can see how that might start to help you to guide you using different inotropes or vasopressors, depending on what combination of values the patient has. The PICO has actually been shown to be quite good at measuring the cardiac output. So it's correlated in this study quite well with the pulmonary artery catheter, showing a mean bias of 0.07 litres per minute. So a difference from the pulmonary artery catheter of 0.07 litres per minute, or 70 mils. And if you're looking at a cardiac output of 4 to 8 litres per minute, depending on the weight of the patient, then that's actually not too big of a difference in terms of, and could be quite accurate in guiding management. The second one to mention is LIDCO. So this is lithium dilution cardiac output measurement. This uses pulse power analysis, which I think is similar to pulse contour analysis, and it uses an algorithm to calculate the cardiac output. It also uses calibration, but uses lithium dilution rather than thermodilution, and it's good because you don't need to have a CVC, so you can just use a peripheral cannula to inject the lithium. This has slightly lower correspondence with the pulmonary artery catheter thermodilution, with an average of 0.3-ish litre per minute difference between the LIDCO and the pulmonary artery catheter measurement. But it still, I think, shows quite good accuracy in measuring the cardiac output and can be used to guide management as well. And the third one of these is FlowTrack, which uses pulse contour analysis as well, but it doesn't use the calibration. It basically just uses an algorithm to try and adjust for the arterial compliance and to try and keep it accurate. Unfortunately, studies have shown that it's not that good at calculating the absolute measurement of cardiac output, and it has been shown to underestimate by more than 2 litres, which obviously is a significant underestimation if you had a cardiac output of, say, 4 litres rather than 2 litres. But it might be useful in measuring the change in cardiac output, so giving a treatment and then seeing whether it increases or decreases after you give that treatment. So I'm just going to briefly talk about aortic Dopplers as well. So this is using ultrasound to determine blood flow through the aorta. So it works, basically, the ultrasound beams are reflected off the moving blood, and that corresponds to the velocity of the blood. And then you can plot it against time, and the area under the curve is equal to the stroke distance, which is how far a column of blood moves up the aorta with each systole. And then if you times this stroke distance by the cross-sectional area of the aorta, you can figure out the stroke volume, and then obviously that times by the heart rate will be the cardiac output. So this is either measured in the descending aorta or which is via an esophageal Doppler probe. So that would have to go down, by the side of an ET tube and rest in the esophagus, measuring the aortic flow. Or you can do it suprasternally, which I believe is the USCOM device, and that measures the ascending aorta and aortic arch. And this relies on the proportions of blood flow to the brain and the rest of the body being stable, which isn't always the case in your ITU patients. The other problem with this is that estimating the aortic cross-sectional area is quite unreliable. If there's a small change in the probe position, then that can really affect the measurement for the cross-sectional area. And it also, I think I've got a slide on this actually. Yeah, it also assumes laminar flow in the aorta. So yeah, as I say, the aortic cross-sectional area is subject to change very quickly with a change in vascular tone or volume status, and as I said, probe position. And as with all ultrasound techniques, it's user dependent. So it needs someone who knows how to position the probe and how to interpret the findings as well. This has been shown to also be relatively good at measuring changes in cardiac output, but it's not so good for absolute cardiac output measurements. So it can't be relied on to give you actual values. Yeah, okay. So this table is just a brief comparison of and summary of the methods that I've talked through. There are a couple more, but I thought I'd focus on these ones. They seem to be the main ones that I came across when I was reading. So we have the pulmonary artery catheter, obviously very invasive and high complication rate, as I said before, but it is sort of the gold standard, although it's not continuous, it's the gold standard of measuring cardiac output. Then we have our pulse contour analysis methods, so ranging sort of from most invasive to least invasive. These can provide continuous readings of the cardiac output, but require calibration, are also subject to inaccuracy in things like aortic regurg, arrhythmias. And then with the flow track delay, it was shown to be not that accurate in comparison to the pulmonary artery catheter. Then we have the Doppler technique. So as I've just discussed, you need to have, for the esophageal one, you need to have a tracheal tube present, and it relies on that assumed proportion of blood flow through descending and ascending aorta. But they might be useful in tracking changes in cardiac output with management changes. Okay, so in summary, so cardiac output monitoring is a commonly used technique in intensive care medicine, and it's useful in both indicating the morbidity or mortality of a patient and also in guiding treatment, particularly with vasoactive and inotropic medications. We talked about the direct FIC method, which is the gold standard of measuring cardiac output, but it's practically difficult. The pulmonary artery catheter is also quite accurate, but it's invasive with a high complication rate. And then the less invasive methods of cardiac output monitoring are available, but they each have specific limitations and situations in which they might not be so accurate. So overall, the message is that these techniques are available for using for monitoring cardiac output in the ICU, but it's important to consider when these methods are indicated and when they might be inaccurate, or what the pitfalls might be of each method as well. So that's it. These are my references, and thank you very much for listening. Happy to try and answer any questions. Thank you.
Thank you very much, Isabelle. That was amazing. You have just summarized a vast topic into few slides, which is amazing. And everything was very clear. Anybody's got any questions, any comments, compliments? She's worked very hard. Anybody from Microsoft Teams? Any questions? Any experiences you want to share about what methods of cardiac output monitoring you guys have done, come across?
I just want to know which of these we have.
Sorry, you're going to be loud a bit loud.
Isabelle, I just want to know which of these methods we are using and also require ITU.
I don't know. I mean, at Ealing, we're using Pico.
Yeah,
Yeah.
we are using Litco.
We're using Litco at Northway.
I heard it was Lidco.
Going to be hospital.
Okay.
But I haven't come across Lidco personally. But yeah.
All right. Perfect. Anybody from Microsoft Teams, guys? Any questions? Any comments? Any suggestions? Anything at all?
Sorry, that was a great talk, Isabelle. Just from back to mine, I've just got a little quick post teaching questionnaire that I've just put on the chat, and I'll send via WhatsApp. I'd be very grateful if you guys would just fill it out. It's separate to the generic feedback. It's for my audit. Yeah, I'd be very grateful.
Perfect. You've sent it on the chat box, is it?
On the chat box, yeah. And I'll put it on WhatsApp now as well.
All right, thank you so much. Guys, please fill up the feedback for the teaching session. I'm going to be slightly mean because I'm going to mark your attendance of the feedback today. So please, if you can, fill up the feedback form and give us any suggestions that you want us to work on, improve in terms of the teaching sessions. The next teaching session is going to be simulation in the ITU. And we will send you details around start of the next week for that. And after that, there's going to be the consultant-led sort of consultant presentation on NIV by one of the IT consultants the week after that. So yeah, that is the updates. If you can fill up the feedback forms, please, that would be amazing. And also Jay's questionnaire, wherever that is. Did you put up the link in the chat box, Jay?
Yeah.
What is the feedback?
I can put it on again now as well.
Is it this one? Oh yeah.
I've just stuck it on WhatsApp as well. Great.
Thank you so much. We are almost coming to the end of cardiorespiratory system. We have, I think, 1 or 2 sessions left, and then we will move on to the next system. It's going to be probably renal. So good luck. And any other comments, anything else you guys want to talk about? Otherwise, we can wind up. Okay, sure. Thank you, guys. If that's all for today. Thank you for joining. I'm going to turn off the recording. Please fill both of the feedback for the teaching as well as Jay's questionnaire if you can. Thank you. Thank you, Isabelle and Jay.